Welcome to Pathology Snippets.
Plasma cell myeloma, also called multiple myeloma, is a neoplasm arising from the late stage B cells that transforms into neoplastic long-lived plasma cells that are capable of producing complete or partial monoclonal immunoglobulin proteins. So now let's look into the etiological factors in plasma cell myeloma. Various karyotypic abnormalities are commonly seen in these cases, which includes translocation of chromosome 414, translocation 1114, and deletion of the long arm of chromosome 13. Similarly, activation of oncogenes such as MYC and the RAS oncogene are common amongst these cases. Radiation exposure is one of the etiological factors in plasma cell myeloma. It was seen that the incidence of myeloma is high in survivors of the atomic bomb explosion of World War II. Similarly, it is also seen in a higher incidence in people exposed to petroleum products, leather, and also amongst woodworkers. Mutation of anti-oncogenes, which includes the p53 and the retinoblastoma oncogene, is another cause for development of plasma cell myeloma. Now let's look into the pathogenesis of multiple myeloma. There is a post-germinal center B lymphocyte that transforms into a plasma cell, which homes into the bone marrow and turns into a long-lived plasma cell. The interaction of this plasma cell or the myeloma cell within the bone marrow microenvironment, which is comprised of the bone marrow stromal cells, osteoblast, and osteoclast, that is pivotal to the pathogenesis of plasma cell myeloma. Now let's look into the stepwise pathogenesis of multiple myeloma. The myeloma cells attaches itself to the bone marrow stromal cells and secretes osteoclast activating factor. The osteoclast activating factor stimulates osteoblast as well as the bone marrow stromal cell to produce RANKL and other cytokines. Osteoprotegerin is a competitive inhibitor of the RANKL. The multiple myeloma cells release syndecan, which binds to the osteoprotegerin and internalizes them. Now, the marrow has excess RANKL, which stimulates the osteoclasts. Increased osteoclastic activity causes increased release of cytokines from the bone matrix as well. Osteolytic lesions due to bone resorption by these osteoclasts are the hallmark of multiple myeloma. The adhesion-mediated signaling and the osteoclastic activity releases cytokines, most important being the interleukin-6. The interleukin-6 stimulates the growth of the myeloma cells within the marrow. Now coming to the morphological features of the different lesions seen in multiple myeloma. The most common, as we already stated, are the osseous lesions. Multiple bones are involved at the time of presentation, and hence the name multiple myeloma. The common bones involved are the skull, spine, rib, and the pelvis. Similarly, long bones of the limbs are also involved. The disease activity starts within the marrow. The osteoclast slowly starts eroding the cancellous bone and ultimately leads to destruction of the bone cortex. This produces radiologically detectable punched out lesions 1 to 2 centimeter in size, osteolytic lesions. These areas of bone rarefaction are prone to pathological fractures as well. Coming to the gross morphology of these affected bones, the affected bones show features of focal or diffuse osteoporosis as shown. You can also see soft, gelatinous, reddish-brown tumor-like masses within bones. Coming to the microscopy, bone marrow aspiration or a bone marrow biopsy is taken from the radiologically abnormal area, and this is usually diagnostic. The overall bone marrow cellularity is increased in plasma cell myeloma. Myeloma cells contribute for equal to or more than 10% of the marrow cellularity. Myeloma cells can be seen arranged either as clumps or diffusely as sheets amidst the normal hematopoietic elements. As the disease progresses, there will be mild suppression of the normal hematopoietic cells as well. The myeloma cells are seen as small ovoid cells with basophilic cytoplasm, immature round eccentrically placed nuclei with a perinuclear HOF, which is a clear zone that comprises of the Golgi apparatus. There are a few morphological variants of these myeloma cells commonly seen in association, which are binucleate forms of the myeloma cells, immature myeloma cells which shows prominent nucleoli within the nucleus, Mott cells. These are myeloma cells with grape-like inclusions within their cytoplasm. Russell bodies are hyaline globules which are comprised of immunoglobulins. Flame cells or thesserocytes. These are myeloma cells which has an irregular cytoplasmic projection and stain deep purple red with a pycnotic nucleus. The bright red color in the periphery of the cytoplasm is due to the compact immunoglobulins within the area. Now coming to the extraosseous lesions seen in multiple myeloma. The most common clinical manifestation associated with the disease is an associated anemia. Anemia is usually normocytic normochromic. There is a marked increase in rouleau formation. This is due to excess of the paraproteins produced by the myeloma cells. Rarely, you can see atypical plasma cells in circulation as well. Due to the underlying anemia and the excess paraproteins, there is often an elevated ESR seen in these cases. The myeloma cells produce excess of immunoglobulins, amongst which is excess of unpaired light chains. These light chains get filtered through the glomerulus to form Bence-Jones proteins. The Bence-Jones proteins binds to the Tam-Horsfall proteins in the distal convoluted tubule to form tubular casts. These are seen as eosinophilic casts within the renal tubules as shown. Foreign body giant cells forming a reaction around these tubules are also commonly seen. Myeloma neuropathy. There is a polyneuropathy associated with these patients. This is due to infiltration of the myeloma cells into the nerve trunks. 10% patients with multiple myeloma develop systemic amyloidosis. The amyloid chain is an AL type of amyloid, which is formed from the excess free light chains. The excess light chain proteins get misfolded and clump together to form the amyloid fibrils, which is called the AL amyloid. The amyloid deposits itself extracellularly and has a particular tropism to organs like the kidney, heart, liver, spleen, lungs, GIT, as well as the skin. Myeloma cells infiltrate into the main organs like the liver, causing hepatomegaly, and the spleen, causing splenomegaly. Now coming to the clinical features seen in cases of multiple myeloma. Infiltration of the marrow can eventually cause replacement of the normal hematopoietic cells. This is one of the primary causes of anemia, which is the most common manifestation seen in plasma cell myeloma. Release of cytokines and eventual destruction of the bone leads to bone pain and hypercalcemia. Similarly, due to hypercalcemia, amyloid deposits, and infiltration of the kidney by myeloma cells, an associated renal failure is also common in these patients. The excess monoclonal protein produced can lead to hyperviscosity syndrome, which is characterized by headache, visual disturbances, and fatigue. Similarly, the misfolded light chain molecules aggregate themselves to form amyloid deposits, and this can lead to systemic amyloidosis associated with multiple myeloma. Monoclonal protein overproduction can also cause neurological symptoms. Presence of hypogammaglobulinemia, an associated granulocyte dysfunction, a reduction in the neutrophil count, all accounts for an underlying immune deficiency, as a result of which patients with plasma cell myeloma present with recurrent episodes of infections. Due to an underlying thrombocytopenia and a deranged platelet function, there is increased incidence of bleeding tendencies. The FAB portion of the M protein binds to the fibrin and prevents aggregation of the fibrin and an impaired coagulation, which also contributes to this bleeding tendency seen in cases with plasma cell myeloma. A unique syndrome called the POEM syndrome is seen associated with plasma cell myeloma. This comprises of P, which stands for polyneuropathy, O for organomegaly, E for endocrinopathy, M for multiple myeloma, and S for the related skin changes. There are a series of biochemical changes seen in these cases, most common being hypercalcemia. Due to renal involvement, they'll have hyperuricemia. There's an increased beta-2 macroglobulin and other globulins seen in these cases. Excess of paraprotein characterizes the disease. Paraproteins are abnormal immunoglobulins or their parts that are seen in circulation and the urine as well. This is detected by serum electrophoresis and is seen as a narrow homogeneous band within the region of the gamma globulin. This is a demonstration of the electrophoretic band. First and foremost is the albumin peak, followed by an alpha 1 peak, alpha 2 peak, the beta region, and the gamma peak. In a case of multiple myeloma, as we saw, there is a peak in the gamma region which corresponds to the M band. This is commonly the IgG molecules. The next common one is the IgA molecule seen in 25% of the patients. IgD is seen in 1%, but 20% of cases can present with light chain only myelomas. IgM is rare and is seen in less than 1% of individuals with plasma cell myeloma. Two-thirds of the myeloma patients excrete light chains in the urine, which are referred to as the Bence-Jones proteins. This could either be the kappa chain or the lambda light chain. Diagnosis of plasma cell myeloma is based on 5 essential features: presence of hypercalcemia, renal insufficiency, anemia, bone lesions, and the presence of M protein in the serum and urine. The revised International Myeloma Working Group has put forward a diagnostic criteria for myeloma, which includes clonal bone marrow plasma cells of more than or equal to 10% of the total marrow cellularity, or presence of proven bone marrow or extramedullary plasmacytoma, which is a localized aggregate of plasma cells forming a tumor-like mass. In addition to either of these features, you should also have any one of the myeloma defining events. So let's look at what the myeloma defining events are. The myeloma defining events could either be evidence of an end organ damage, which is attributed to the plasma cell myeloma, or it could be one of the biomarkers of plasma cell neoplasm. So now let's look into the features that are evidence of an end organ damage that is attributable to plasma cell myeloma. This includes elevated serum calcium of more than 11 milligrams per deciliter, renal insufficiency that manifests as elevated serum creatinine of more than 2 milligrams per deciliter, anemia with a hemoglobin level of less than 10 milligrams per deciliter, presence of osteolytic lesions, which is one or more, that is detectable by an X-ray, CT, or a PET-CT scan. This is given a diagnostic acronym of CRAB, where C stands for calcium levels that are elevated, R for renal insufficiency, A for anemia, and B for bone lesions. The biomarkers for malignancy are clonal plasmacytosis of more than 60%, a ratio of the involved and uninvolved serum free light chains of more than 100, and presence of more than one focal lesions that are detectable only by an MRI. The treatment for plasma cell myeloma is chemotherapy regimes, immunotherapy, and stem cell transplantation. Staging of the disease is one of the forms of prognosis assessment. The staging system used in plasma cell myeloma is the Salmon and Dury staging, which uses hemoglobin, serum calcium, presence of the lytic lesions, and the M component to categorize patients into 3 prognostic groups: the low, intermediate, and the high risk categories. However, the overall prognosis of the disease is very poor. So with this, we come to an end of plasma cell myeloma. Thank you.